Clavicle fracture. Clavicle shaft fractures are common traumatic injuries seen in young adults. These fractures account for 2 to 4% of all adult fractures. Junction of outer and middle thirds is the thinnest part of the bone and it is the only area not protected by or reinforced with a muscle and ligament attachments. 75 to 80% of all clavicle fractures will occur in the middle third segment. 10 to 30% of all clavicle fractures occur in the distal third or a lateral third segment. Fall on an outstretched arm or a direct trauma to the shoulder is a common cause for clavicle fractures. Classification. There are two classifications for clavicle shaft fractures. Non-displaced, it is less than 100% displacement. Displaced, more than 100% displacement. It is a nearest classification. Here classification: type A simple, type B wedge, type C complex fractures. There is one more classification for lateral one third of the clavicle fractures by knee. They classify into 1 to 6. Coming to the treatment. Majority of the clavicle fractures can be treated by non-operative method with the use of a sling. Figure of 8 brace is not required. There was a prospect studies on functional and cosmetic outcomes between a sling and figure of 8 brace treatment. There is no difference in the end result. You can just put a arm sling to support the arm. Absolute indication for the surgery are open fractures, displaced fracture with a skin tenting, impending skin injury, subclavian artery or a vein injury, floating shoulder, clavicular and scapular neck fractures, symptomatic non-union, symptomatic malunion are the absolute indication for the operative treatment of clavicle fractures. There was a study on lateral and clavicle fractures in JB's 2009. Displaced lateral fractures have high risk of non-union after non-operative treatment according to this study. Non-union is difficult to predict and may be asymptomatic in elderly individuals. Results of operative treatment are more unpredictable than they are for shaft fractures. In these two X-rays you can see a operative treatment of lateral and clavicle. In first X-ray it was fixed with a hook plate. In the second X-ray the lateral end was fixed with a tightrope technique. Aldose and clavicle fractures. Regardless of patient age, sports participation and final clavicle shortening, no difference in pain, strength, shoulder range of motion or subjective outcome scores were found between the injured and uninjured limbs of adolescents treated non-operatively for displaced shortened mid-shaft clavicle fractures. That means majority of the fractures can be treated non-operatively in adolescents. You have to operate only if absolutely indicated. There are two papers published in JBJS, one in 2014 and one in 2017 on mid-clavicle fractures, whether to do surgery or no surgery. There was no demonstrable difference in a limb function between the patients who underwent a surgical treatment and those non-surgically treated for a dislocated mid-shaft clavicle fractures. The potential for unnecessary operations is particularly relevant because surgical management of clavicular fractures has a significant rate of complications and a nearly 25% rate of reoperations. Conclusion of these two studies is you have to treat mid-shaft clavicle fractures non-operatively. Mid-shaft clavicle fractures, surgery or no surgery. Because the majority of displaced clavicle fractures will heal well with non-operative management, initial conservative care followed by surgical fixation for those 15 to 18% of patients who go on to non-union is a reasonable strategy. This has been confirmed to be cost effective also. Does a delay matter? Delayed surgical care generally results in the same excellent clinical and functional outcomes as immediate surgical fixation. Coming to the complications of clavicle fractures. Complications of non-operative treatment are non-union. It is almost 10 to 15% of the conservative treatment. In that, majority will be asymptomatic. Malunion. Complications of operative treatment, hardware prominence is seen in 30% of patients, which will require implant removal. Neurovascular injury 3%, non-union 1 to 5%, infection 4.8%, mechanical failure 1.4%, pneumothorax, adhesive capsulitis 4%. That means almost 40% of patients treated by operative treatment will have a complications. Now we'll discuss evidence-based recommendation for clavicle fractures. Fracture type and technique. Grades of recommendation. Acute displaced clavicle fracture, plate fixation. There is a very poor quality evidence for plate fixation. Very poor quality evidence for intramedullary fixation. Non-union after type 2 fracture, plate fixation with a bone graft, fair evidence. Intramedullary fixation with a bone graft, poor quality evidence. Lateral and clavicle fractures, coraco-clavicular screw fixation, poor quality evidence. Plate fixation, poor quality evidence. Conclusion. Undisplaced fractures of both the diaphysis and lateral end of clavicle have a high rate of union. Functional outcomes are good after non-operative treatment of displaced fracture also. There is a currently considerable debate about the benefits of primary operative treatment of clavicle fractures, but evidence does not support operation for all displaced fractures. It remains difficult to predict which patients will have a complications or which patient will go for a non-union. Operate only if absolutely indicated.